Katie, let's transition a little bit to Frontline PARP. We've now had 3 New England Journal papers in 3 years. 4 New England Journal papers in 3 years. 4 papers, 3 years in the New England Journal that changed the treatment in ovarian cancer. Yours was last year. We're like on the year anniversary. So teach us about frontline PARP inhibitors in newly diagnosed advanced ovarian cancer and your wonderful study, SOLO-1.
SOLO-1 was actually launched in 2013, so a long time ago, and just reported last year because of how well the patients did. But it was really the first time we incorporated PARP inhibitors into the frontline treatment armamentarium. So it was the first opportunity to do that, and it selected the patients who were at highest likelihood to benefit, which were those women with BRCA-associated cancers. So it enrolled women with advanced stage disease that was BRCA related. They had to have an attempt at a surgery. And at the end of their induction platinum-based chemotherapy, which they had to have at least 4 cycles of, they had to either be in complete or partial response. So this is an important kind of distinction, because this really ushered in this era of switch maintenance, which is different than what we just talked about earlier with bevacizumab, with just like continuous maintenance. So this is really not the very first, but one of the first opportunities to look at this sort of a strategy. The primary endpoint for this study was progression-free survival, and secondary endpoints were overall survival, and there's a number of others, including quality of life. So we presented the progression-free survival at ESMO in 2018, and with a median of 42 months of follow-up, which is double that what we saw yesterday.
That's right.
Because that's how long it took to get to the endpoint. We still had not reached the median progression-free survival for the women who were treated on olaparib. The women who were not treated on olaparib had a median progression-free survival of 13.2 months from the end of chemotherapy, and the average time on chemotherapy was 7 months, so it's about 20-month progression-free survival for the control group and about 49-ish for the treatment arm, with a hazard ratio of 0.3.
So 14 to 50, almost 36 months.
Right. We think we improved progression-free survival by about 3 years.
Unbelievable. And put that in perspective to what you said about bevacizumab. So bevacizumab was a hazard ratio of 0.62. All comers, I get it, with about 6.2 months. Now you have half of the hazard ratio, 0.3, and 30 months, like 5 times the median. So that was really exciting.
And if you look at those curves, right, when Bev is stopped, curves come back
Falls
together.
back down. That's right.
But the effects from PARP inhibitors in SOLO-1 seem to be lasting.
And it was oral treatment for 2 years.
Correct.
Now, Rob, let's just set the stage here. So tell us how PARP inhibitors work, just so we can understand that.
Yeah, I think the easiest kind of way of thinking about the PARPs, the one that we talk about frequently, is that PARPs are responsible for base excision repair, and when we inhibit that, it statistically makes it more likely that the cell will have a double-strand break. It can also trap, so this double-strand break. And then it relies on homologous recombination to fix, because it's a high-fidelity system of the many systems that can fix DNA. That homologous recombination response is the highest fidelity through the BRCA-driven mechanisms. So tumors that are vulnerable because they don't have a homologous recombination compliancy, so we call it HRD, or homologous recombination deficiency, then those cells are sick and they die. They're unable to fix the DNA damage that we've induced. So we statistically promote the opportunity for the double-strand break to happen, and then take advantage of the fact that the cancer cell can't fix itself. So that's the
synthetic lethality.
Yeah, or sickness. Yeah. So those terms have been used kind of interchangeably as a way to look at that concept. So you have 2 non-lethal events that lead to a lethal event.
Yeah. So PARP repairs single-stranded DNA breaks, and if you inhibit that, then you form a double-stranded break, and BRCA repairs double-stranded breaks.
Correct.
And so an unrepaired single-stranded break, an unrepaired double-stranded break, apoptosis. Now you talked about this HRD, so it's not just BRCA,
right?
That the sister chromatids, the homologs can be lined up, and the double-stranded breaks can be repaired through BRCA-like genes, and you call that homologous recombination. So let's spend a few more minutes here and then transition to what we saw at this meeting about how do you test for HRD. I get it, we test for BRCA,
Yeah.
but we really don't test in this company for homologous recombination repair deficiency, but we can. Tell me, Michael, how we can test for HRD.
Yeah, so the historic perspective here is we've always been interested in sequence BRCA1, BRCA2. Then we learned there are probably some other genes that are important, sequence them. And it became clear that that's a lot of work, a lot of money, and would there be functional measures of this homologous recombination deficiency? And so it was observed once these big genomic databases were available that you could look at the BRCA patients who we knew had mutations compared to everybody else. And they had different patterns of what we call loss of heterozygosity. So when you have a DNA repair abnormality, like homologous recombination deficiency, the cell loses pieces of DNA, and you can map that.
Right.
So LOH is the basis of these HRD assays. Foundation Medicine has a relatively pure LOH assay. Myriad has an LOH assay, and then they add on to it something called telomeric imbalance, allelic imbalance, which is because the telomeres are so far out at the end of the chromosomes that it's hard to map them. So they add that in specifically. And then they also have these large-scale transitions, which are so big, you can't map them with LOH. So the two assays are very similar, I think, a little more complex with Myriad, and they're looking at a functional state of homologous recombination deficiency.
And both the LOH high and the Myriad HRD assays are commercially available. So Shannon, I get it that we're supposed to test for BRCA, right? Do you think the community is doing HRD in newly diagnosed advanced ovarian cancer?
Not generally, no.
But go ahead.
No, I mean, I think that with the data that we had previously, there wasn't really a reason to get HRD up front, right? We wanted to find out from, since we know from Dr. Moore's SOLO1 data, we wanted to get that BRCA information right away, not just germline, but also somatic, right? And there's a small proportion of that trial. Still, the thought would be that you're going to get benefit, really small.
Two.
But still, good information. But we didn't have a reason to look for that HRD right away up front.
Yeah, I think that's a point to emphasize with Katie's talk. Is that Katie's point is that now that we have this you made a big deal about that big effect, so that then drives home the fact that we need to know this information. Yes. And so that testing, as you just mentioned, is now, I think, is essential.
So all BRCA patients are HRD, is that right?
So, I mean, based on what we know scientifically, all BRCA patients are going to be HRD positive. So it gets a little bit complicated in terms of the nature of the mutation, but we're not there yet.
But so maybe when we say HRD, we should maybe take the BRCA patients out, because all BRCA patients are HRD, and we'll get into that. And this is one of the key take-home messages of today, is that we're going to talk about data from Frontline PARP inhibition, and there is an opportunity in this HRD beyond BRCA.
Absolutely.
And that's why at this meeting, the first 3 presidential session papers were all ovarian cancer based, and 2 of which have already been published in the New England Journal.